Good morning, everyone. I'd like to thank the committee for giving me this opportunity to speak about how the Eighth Amendment currently affects the practice of pharmacy in Ireland, and more importantly, the implications of its potential removal from our Constitution. Firstly, I will address the government's proposals to bring in medical abortion as the main method of termination up to 12 weeks if the referendum is passed. Secondly, I'll discuss the current two-patient model of treating patients in pregnancy in the context of our Code of Ethics and duty of care to all patients, born and unborn, which is supported by the Eighth Amendment. Finally, I'll address the ethical issues which will arise if we vote away the right to life of a cohort of our patients on May 25th. So the first principle of our Code of Conduct as pharmacists is directed to maintaining and improving the health, well-being, care and safety of the patient. We're told that our primary focus should be the health of our patient, which brings us to the question, who is our patient? This is answered very clearly in the Code of Conduct itself, from which I will quote directly. For the purposes of this Code of Conduct, a patient includes a person or persons who stand in such a degree of relationship to a pharmacist that the pharmacist ought to reasonably apprehend that such a person or persons' health, well-being and care are likely to be affected by the acts or omissions of that pharmacist. Now, in what other situation can a patient present as persons, if not the pregnant mother and her unborn child? Therefore, we can safely establish from the Code of Conduct alone that the unborn child is indeed our patient. In pregnancy, I have an ethical responsibility to two patients, the mother and her unborn child, and both patients are currently protected under the Eighth Amendment. It's important to note that women are entitled to get all the medical care they need to protect their life and health during pregnancy under the Eighth Amendment. Drugs are used in pregnancy all the time to treat either pre-existing health conditions or conditions which arise during pregnancy. Evidence-based practice guides the use of these drugs and informs us where relevant of the potential effects of these drugs on the developing baby in utero. Up until now, our focus has been to treat women with health conditions in pregnancy with the appropriate drugs, with due regard to the effects these drugs will have on the fetus, while not compromising the care of the mother. This has all been facilitated by and is permissible under the Eighth Amendment. In a nutshell, under the Eighth Amendment, I've been able to treat mothers during pregnancy whilst doing my best to protect the baby also. So coming from a position where we've done our best to not only protect the life but the health of the baby in utero, how do we go from there to dispensing drugs which will intentionally end the life of the baby in utero? This duty of care to the unborn patient is manifested clearly in the current cautionary approach to the use of highly teratogenic drugs and the stringent measures in place around their prescribing as far as practically possible to reduce or avoid the exposure of these patients to the drugs in utero. We're all very aware of the thalidomide tragedy, which interestingly led to compensation entitlements for the parents of the babies injured between the time of conception and birth. The English Law Commission recommended that compensation be claimable for preborn babies injured in the womb by the fault of another. The United Nations declared in 1959, the child, because of its physical and mental immaturity, needs special care and safeguards, including legal safeguards, before as well as after birth. This was a preamble to the Declaration of the Rights of the Child, published in the United Nations Office of Public Information in February 1973. Last week, as I was researching, I came across a recent advisory on the HPRA website, that's the Health Products Regulatory Authority, which describes a series of new safety measures being introduced and endorsed by national medicines agencies across Europe to avoid exposure of babies to valproate medicines in the womb due to risk of birth defects and developmental problems. In light of the current debate, I was happy to see the reference to actual babies in the womb. I decided to check the SPCs for a couple of other well-known teratogenic drugs to see if there was a consistency to the language used in describing the teratology of these medicines. I'm sure most of you are familiar with an SPC. It's, just to clarify, it's a summary of product characteristics, so it's a description of a medicinal product's properties and conditions attached to its use. I was reassured to see the following descriptions used when describing babies in the womb. So with reference to valproate, which is an anti-epileptic medication and is highly teratogenic, we have a reference to the physical development of the exposed children. Then with reference to isotretinoin, which is better known as roaccutane, and it's used for acne, its use, we see the reference to the risk of serious malformation of the fetus. And then thalidomide, probably the most famous teratogenic drug, we see that the mother must understand the teratogenic risk and the references to the unborn child. In contrast, when I went to do my research on the abortion pills, mifepristone and misoprostol, I noticed that the words child, embryo, fetus had all but disappeared from these SPCs. Instead, I saw words like pregnancy tissue, products of conception, uterine remains, uterine contents, used when describing the mechanism and effects of these drugs. I found this quite shocking, and it must lead us to ask ourselves, if there's nothing morally reprehensible about the intended effect of these drugs, why the need to change the language in describing the unborn child? On the one hand, we have an SPC outlining how to reduce risk to the unborn child, while on the other hand, we have an SPC all but denying the reality of an unborn child. This brings me to the arduous task of describing what a medical abortion is from a pharmaceutical perspective. So medical abortion is the use of a medication to end pregnancy. Most commonly used medicines are the mifepristone misoprostol regimen. It involves the sequential use of mifepristone orally, followed 36 to 48 hours later by misoprostol, which can be given by various routes. So what is mifepristone? Mifepristone is a synthetic steroid with an anti-progestational action as a result of competition with progesterone at the progesterone receptors. It antagonizes the endometrial and myometrial effects of endogenous or exogenous progesterone and sensitizes the myometrium to the contraction-inducing action of prostaglandins. Mifepristone also induces softening and dilation of the cervix, most apparently at approximately 36 to 48 hours after administration. Mifepristone also binds with high affinity to the glucocorticoid receptor. Misoprostol then is a synthetic analogue of prostaglandin E1. At the recommended dosages, misoprostol induces myometrial contractions and relaxation of the cervix. The uterotonic properties of misoprostol thus facilitate cervical opening and evacuation of the uterus. Gemaprost is another prostaglandin analogue which is used. It's not used as much as misoprostol. It's administered PV only and is used generally at later gestations, and it must be stored at less than -10 degrees. I don't intend to go into any more detail here on the various products, but to suffice to say, there are different formulations and dosing regimens licensed throughout the world. In the UK, this regimen is licensed up to 9 weeks gestation and 10 weeks in the US. The licensing of this product is relevant when we think of it in the context of its use here by GPs. Will we be the only jurisdiction using it up to 12 weeks gestation? Are GPs happy with this potential off-license use, taking into consideration that the burden of responsibility will then not lie with the drug company, but with the individual prescriber? Of further concern, very few interaction studies have been performed on these drugs, and this is significant as many women are on regular medications. As mifepristone is metabolized by the cytochrome P3A4 enzyme system, caution should be exercised when it's administered with drugs that are substrates of this enzyme system and have a narrow therapeutic range. Due to the long half-life of mifepristone and its slow elimination from the body, such interaction may be observed for a prolonged period after its administration. There are numerous contraindications to the use of this medication regimen. It includes the following, so most importantly, confirmed or suspected ectopic pregnancy, chronic adrenal failure, concurrent long-term corticosteroid use, history of allergy to any of the medications, hemorrhagic disorders or concurrent anticoagulant therapy, and inherited porphyrias. Despite the portrayal of medical abortion as a somewhat cleaner, safer method than surgical abortion in early pregnancy, the medical risks to the mother are very real. The top 5 serious risks include hemorrhage. Women bleed for an average of 9 to 16 days with these medications, and in fact up to 8% of subjects may bleed for more than 30 days. In general, the duration of bleeding increases with increasing gestational age. Excessive uterine bleeding, which happens in 5% of cases, usually requires treatment by uterotonics, vasoconstrictor drugs, surgical uterine evacuation, administration of saline infusions, and may necessitate a blood transfusion. The second risk is infection. Serious cases, including fatal cases of toxic shock and septic shock following infections with atypical pathogens, such as Clostridium sordelli, have been reported with medical abortion. An important feature of these cases is the atypical presentation of infection. Very rarely, deaths have been reported in patients who presented without fever, without bacteremia, or any significant findings on pelvic examination following an abortion. Thirdly, missed ectopic pregnancy. An ectopic pregnancy is a contraindication for medical abortion. Unfortunately, the cramping and bleeding expected with mifepristone mimics the signs and symptoms of a ruptured ectopic pregnancy. This causes women with undiagnosed ectopic pregnancies who use mifepristone to delay seeking emergency treatment and risk death. There have been 58 cases of mifepristone use with an ectopic pregnancy reported to the FDA, including 2 deaths. Incomplete abortion is another risk. In general, the failure rate of medical abortion is 1 to 8%, depending on the method regimen used and the parity age of the woman. Incomplete medical abortion usually ends up as surgical abortion. The incidence of incomplete abortion was very pronounced in a large-scale Chinese study of mifepristone use, which is published in the Archives of Gynecology and Obstetrics 2011. And this study found that 20% of medical abortions required subsequent surgical intervention because of retained fetal tissue. Finally, continuing pregnancy. I think it's awful that one of the risks listed is the continuation of pregnancy, i.e. the survival of the baby, when in most other healthcare regimens, survival and health are the desired outcomes. The worst possible outcome in one treatment becomes the desired outcome in another. It's worth mentioning a Finnish study, which was published in the Journal of Obstetrics and Gynecology in October 2009, which concluded that the overall incidence of adverse events was 4-fold higher after a medical abortion than the surgical abortion method. In the US, mifepristone is a subject of extensive FDA restrictions based on pre- and post-marketing experience. Attached to it is a risk evaluation and mitigation strategy, which is used for drugs where the potential risks outweigh the benefits unless stringent controls are in place. The FDA reports 22 deaths in the 17 years since licensing in 2000 from ectopic pregnancy and several due to sepsis. 2 from ectopic pregnancy and several due to sepsis. As a result, there's a certification process for healthcare professionals using these drugs, and they must demonstrate an ability to date pregnancies accurately and to diagnose ectopic pregnancies. They must be able to provide any necessary surgical intervention or have made arrangements for others to provide such care. They must ensure that women have access to medical facilities for emergency care, among other responsibilities. Are these considerations being taken into account by our government as they seek to introduce a GP-led medical abortion service, unrestricted up to 12 weeks gestation, onto an already overstretched primary care health service? This brings me on to the topic of conscientious objection. So what about conscientious objection if we have to dispense these medicines? Removing the Eighth Amendment will not only remove the right to life of the unborn, but it will also remove our right as healthcare professionals to endeavour to preserve life. If all legal protection is removed from the unborn child, where does that leave my duty of care to him or her? The right to conscientious objection has been eroded for the most part in the majority of countries where abortion is legal. If we repeal the Eighth Amendment, the most fundamental human rights of our youngest patients will no longer be recognised, and there will be a direct conflict between the law and my ethical responsibilities as a pharmacist. Is it okay to abandon my duty of care to one, if not both, my patients? Will I be forced to act against my ethical obligation to protect and preserve the life of one patient and to protect and preserve the health and well-being of the other? It's also interesting that pharmacists are not mentioned at all in the proposed legislation when it comes to the rights of conscientious objection. It seems to me that if the Eighth Amendment is removed, it will contradict some important aspects of our code of conduct, namely the efforts to, quote, not purchase or supply any product which may impose a hazard to a patient's health or well-being. Secondly, to encourage the rational and proper use of medicines. To ensure discriminatory practices, thank you, are not demonstrated towards any class of patient or sector of the community. And perhaps finally, most importantly, to ensure the patient is at all times acknowledged as a person. These are all stated in our Code of Conduct. If the Eighth Amendment is removed, we'll have to reset the goalposts when talking about ethics. As a pharmacist, my focus has always been on obtaining the best possible health outcomes for my patients. This is what attracted me to the profession and what I was trained to do. Sometimes drugs dispensed in pregnancy are not just to maintain the mother's health, but to maintain the health of the baby in utero. A classic example is the use of progesterone support in early pregnancy in order to maintain the pregnancy if the mother's levels are compromised. If the Eighth Amendment is repealed and the use of abortion pills becomes legal, how will I reconcile the use of one drug to help protect the life of certain developing babies, whilst on the other hand another drug will be used to deliberately end the life of other developing babies? How can I interchange these irreconcilable roles? Surely either all babies are worthy of my care and consideration, or none. The idea of choice and bodily autonomy, I'll just be very quick on this, but I just think it's an interesting concept. Of course, a woman has a right to bodily autonomy as far as it affects her body. However, in pregnancy, there are two bodies involved, and once a person's right of bodily autonomy starts affecting another person's body, there has to be a limit. The unborn baby has a right not to have their bodily autonomy violated through abortion. In fact, even our own bodily autonomy is limited to a certain extent when it comes to medicine and healthcare. We're not given free rein over what prescription medicines we can take, for instance. These measures are in place for our safety and protection. In fact, again, it's stated in our Code of Conduct that we must, quote, endeavour to ensure the safety of the patient is at all times, the safety of the patient in all circumstances by decision making, which may at times conflict with the stated requirements of the patient. It's not always the patient's choice that takes precedence. The concept of choice is superseded by the professional duty of care in this instance. Therefore, why should we only exercise this notion of choice when it comes to the care of our youngest patients? Why can't we afford them the same level of safety and protection? Again, to go back to the Code of Conduct, we must, quote, safeguard society as a whole by ensuring that the protection of vulnerable individuals is given due significance. Who can be more vulnerable than the baby in the womb? To conclude, as a profession, I think we've always had an innate inclination and desire to protect life and health as far as practical. I believe this is a key value for most healthcare professionals. We really need to reflect on this as we consider the implications of removing the most fundamental of human rights from our second patient, namely the right not to have his or her life deliberately harmed or ended by the very people who should be caring for and protecting them. Thank you for listening.